diagnosis of schizophrenia if there is a known substance use disorder going on in that particular case. That individual is excluded from research. So everything that we call evidence-based practice, especially pharmacotherapy, is derived from patients that don't have substance use disorders. In other words, derived from patients who represent a statistical minority of individuals with schizophrenia. So I think the advantage of having a forum like this ECHO forum is that we can talk about real world cases, because this is a very good example of how the real world deviates from the theoretical, sometimes bordering on fictional world of pure evidence-based practice. So this is the catchy title slide. Oh, and I have the controls, so there we go. So Claire, is it possible that we could move the banner from the tops to maybe the side? Yeah, thank you. So for you guys who can't see, there's a banner of icons that obliterates the title slide, the title of your talk. So this talk is about drugs, but I'm going to reframe the question, because we culturally, historically, when we think about substance use, we think, oh, that person should stop using drugs because then things are better in their life. So, and absolutely, I think stopping drugs is advantageous for reasons that will become obvious in a couple of slides from now. But I would like to begin this talk and sort of frame this discussion by flipping the question from how do we get so-and-so to stop using marijuana to how do we get so-and-so to have the highest opportunity for recovery and full restoration of function. And I think that it is, we get really focused on the drug and the medicine and the drug and the this and the chemical and the chemical. And the way that we tend to historically think about substance use disorder is reminiscent of this well-stated but very snarky quote by Thomas Szasz, who points out that speaking about addiction and drugs because addiction involves drugs is similar to thinking about baptism as a chemical problem because baptism involves water. There's a whole lot more that goes on with substance use beyond just the reinforcing effect of the drug or the pharmacological actions of the substance of abuse. Can you advance for me, please? Sorry guys, I'm having a technical problem. I'll try this from here. No? Is the computer blocking the... Yeah, maybe works better.
Really nice. Got it off of the title. Huh.
What if you tried the other one, Claire, and see if you can just flip through that one?
Down the side.
There we go.
Was that your? Okay.
All right, I'll ask you to press it.
Okay.
Okay, sorry about that. There was a communication error between my slide advancer and where the slides are living. So with the frame of let's try to talk about how best to promote recovery and healing, I want to point out. Well, I want to remind people what I think everybody knows in the back of their heads, but I really want to put this at the forefront. All of medicine rests fundamentally on the fact that the body is designed to heal itself. It wants to restore itself to physiology. In physiology, we call it homeostasis, balance. It wants to repair. It has the body and its brain have an incredible inborn, innate ability to repair itself. And so what we need to do, the basis of all medicine, is setting the conditions in which that repair can happen. The graphic is showing a broken heart with a Band-Aid. You can easily see that as broken skin. I mean, the simplest thing is when you have a cut, you simply bring the tissue together and the body does the rest of the work. If you have a broken bone, you bring the bone together and the body does the rest of the work. If you have any number of conditions, if you simply set the right environment, the body will do half or more of the work. And so in psychiatric care, this principle applies, and these bullet points are common sense, but worth repeating. Foundational elements for any repair, and particularly for those involving mental illness, are good sleep, adequate diet, robust activity. We're designed to be active. That's in our DNA. We're also designed to be members of communities, and in our communities, we're designed to help our fellow man. So community and purpose are of paramount importance in healing processes. And I emphasize this because in the modern environment, which is over-focused on medications, we tend to lose sight of the fact that loneliness and purposelessness are massive drivers of anxiety, depression, psychosis, and substance use. So we can really help our clients well in any facet of their life by always reminding about these fundamental important elements of their nature. So let's try the next slide. Thank you. And in addition to those basic foundational elements, psychiatrists or mental health professionals, we can also deploy more specialized treatments to try to better facilitate healing. And a lot of these are elements of coordinated specialty care. So we can support our patients to develop their community and purpose or reattach to those things. We can help them through individual resilience training or through formalized psychotherapies like CBT to develop the skills to reframe or cope with the symptoms that are perhaps emotionally disturbing. And if we can minimize distress from experiencing hallucinations, for example, then that stress feeds back to make those symptoms less likely to happen. We can also, in some settings, actually, we can also encourage the brain's natural plasticity response and engage our clients in cognitive exercises, cognitive enhancement therapy, or metacognitive remediation therapy. And these two particular therapies, in addition to rehearsing or practicing the circuit cognition, also serve to practice circuits devoted to social cognition or socialization skills. So those are things that we can do within coordinated specialty care that can further boost outcomes. And then people from my tribe of medicine and psychiatry, we can also add to that mix by perturbing physiology in ways that will help to normalize the body's neurochemistry, making positive symptoms like hallucinations or paranoia or undue suspiciousness or anxiety or depression to become less intense. And as we can normalize the physiological substrates of those symptoms, we allow our patients to be better able to focus on these foundational elements as well as on the specialized care elements. So next slide, please. And so just to, and it also goes without saying, but we've talked for a couple of slides now about the things that you should do. And there are a couple of things that you should, if you're going to, with this narrative of setting the environment for optimal healing, you want to avoid unnecessary or excessive stress, situations, people, and so forth, as well as you want to do everything in your power to avoid exposure to chemicals which can perturb body chemistry in ways that are more likely to provoke psychosis. So next slide, please. And what are some examples of chemicals that can perturb or provoke psychosis? This is an incomplete list, but this is, we'll say, the top 7. And I rank them in basically descending order of importance. The most heinous of the offenders are the synthetic cannabinoids, K2 and spice. These things are like they're purely evil. I can't tell you the number of 40 and 50-year-old people who decided, yeah, I'm going to use some of that, and they wind up with multiple years of bipolar manias or schizophrenia-like conditions. These things are they're poison. Next is marijuana, and amphetamine is listed below this. And actually, if you look at the risk data, marijuana and amphetamine are almost on the same level. So they could actually be related by an equal sign. Amphetamine people kind of know about, and I'll talk more about amphetamine. I'll talk more about amphetamine and marijuana in coming slides, but those are on the list. Cocaine is also psychotogenic. Opiates can be. This is a much lesser known side effect of opiate exposure, but indeed there is a certain segment of the population who, when they are exposed to any kind of opiate analgesic, codeine, tramadol, fentanyl, and so forth, will develop frank psychosis. Yeah, no, true. I'm getting some looks like, really, and yeah, as a hospitalist, as a consultant to the surgical floors, this was a routine call, so it happens, and it's out there. Alcohol is, on the lower tier, but again, some people are very, very vulnerable. It doesn't per se cause hallucinations, although withdrawal can. And it tends to more provoke sleep disturbances and anxiety conditions, and those can have secondary knock-on effects to destabilizing psychosis. And caffeine is indeed the lowest tier. It is, for most people, benign from a psychiatric side effect point of view, but there is, in fact, a small number of people in the population for whom caffeine can provoke symptoms that are almost identical to mania, or symptoms that are almost identical to psychosis. It's a minority group. But I mention this because you all who are listening to this will have people in your caseloads who I call with vulnerable nervous systems.
Can I ask you a question?
Oh, go ahead.
Sorry, does it matter the amount of caffeine? Because I know people that have schizophrenia that are addicted to monster drinks. And it seems like the more they drink of the monster drinks, the more psychosis they have.
Yeah, no, it's absolutely, it's dose dependent, and the more the dose, the more likely the adverse effect. And just, well, thanks for the question. And as we don't have cases lined up, I guess I will expand a little bit in talking. So caffeine is a very, very interesting drug because it's widely available. We tend to think of it as not really that powerful of a psychotropic agent. But if you are found unconscious by paramedics, they'll, in the field or immediately after they bring you to the hospital, a couple of things are going to happen. You're going to get an injection of a lot of glucose because you might have insulin. You might have hypoglycemia, and getting a big dose of glucose will reverse that. And they do this without thinking because these are things that are low cost but high yield. You'll get a shot of Narcan or naloxone because it could be that you're obtunded due to opiate intoxication, and the Narcan will reverse this. And you'll get 200 milligrams of caffeine intravenously. And 200 milligrams of caffeine is just about one tall coffee from Starbucks. So in my fantasy clinic, I will be a sleep disorders clinic, and I will have people for their first assessment come in at 8 p.m. and I'm going to get a saliva sample and I'm going to measure the caffeine level because people say I can't sleep, and they've had during the course of the day 4 doses of emergency room level stimulant and so forth. So it's the narrative that's a story to just highlight one portion of caffeine is actually really powerful psychotropic. But caffeine is more interesting because it blocks the receptors for a neurotransmitter that few people have heard about. That neurotransmitter is called adenosine. So caffeine is an adenosine receptor antagonist. And what's the importance of that? I'll tell you. If you have animal models of psychosis and you give them drugs which stimulate the adenosine receptor, you will normalize that behavioral analog of psychosis. If you give to animals or to humans drugs which augment the adenosine signal, you will have a anxiety reducing and an aggression reducing effect. So adenosine receptors are actually very, very important for several facets of behavior. You don't know about them because getting drugs to directly stimulate them is quite hard. We don't have things we can use in humans yet for that purpose, but we do have adenosine receptor antagonists, and that's caffeine is one of them. So caffeine, so the ability of caffeine to provoke psychosis probably is mediated by its adenosine receptor blocking effect. And I think some schizophrenias are very tightly related to adenosine receptor abnormalities. And also, for extra credit, there are some drugs. One of them you can use to treat gout. That drug is called allopurinol. Allopurinol indirectly augments the signaling of adenosine in the brain, and allopurinol turns out to reduce psychosis when it's given as an add-on medicine to antipsychotic drugs. So the science is a little bit, well, it's in the science journals, not the medical journals, but it's clear that there is a signal for caffeine to be psychotogenic. Again, for most people, it's not an issue, but for people with vulnerable brains and vulnerable brains plus high doses, it actually does become quite possible that it can be a destabilizing force. And I've had a number of schizophrenia affected people who eventually find out for themselves that that using this level of caffeine makes them worse rather than better. So they decide to stop because they realize that either staying out of the hospital or being able to get a job or being able to be free from disturbing symptoms is worth it motivates them to be able to experiment with longer term abstinence or dose reduction from caffeine. So thank you for that question. So anyway, this is my list of some chemicals which can be work in the opposite direction to where we would like folks to go. Let's move to the next slide. So a few words about amphetamine. When it is abused, we hear about meth or methamphetamine, which is just a very simple derivative of ordinary amphetamine. Methamphetamine makes it a little bit more permeable to the brain, but amphetamine and amphetamine are highly brain permeable. Both of amphetamine and methamphetamine work by causing the cells in the brain to release large quantities of dopamine. And as you know, I think excessive signaling of dopamine is the primary reason why most people suffer from hallucinations, paranoia, delusions, and the so-called positive symptoms of schizophrenia. And all of schizophrenia pharmacotherapy, with the exception of clozapine, is based upon the idea of blocking receptors for dopamine. So this gives you an idea of the importance of dopamine to the generation of psychotic symptoms. And amphetamine and methamphetamine are strong dopamine-releasing drugs. So therefore, they're widely known to be potent psychotogenic chemicals. Experiments that were done in the 50s on ordinary college student volunteers showed that basically everybody will experience psychosis if given enough amphetamine. So their ability to provoke psychosis is unquestioned. Amphetamine is the active ingredient in almost every drug that's used to treat ADHD. Our pharmaceutical industry colleagues discovered that you can take amphetamine and you can put it into delayed release formulations or gummy bear formulations or any number of things, and you can get that stuff patented. And when you get it patented, you can sell very cheap amphetamine for very high level pricing. And so there's a campaign underway to convince everybody that there's ADHD has been underrecognized and that any form of concentration impairment should raise suspicion for ADHD, and therefore we should offer people amphetamine, patented amphetamine. So I'm harping on this because this is a bastardization of the patent laws, and it is a crime against humanity because in real life, amphetamine causes psychosis. And how often can that cause psychosis? Well, according to 2 studies from Canada, I have one citation here, up to 6% of individuals who are given therapeutic doses of ADHD medicines for presumed ADHD will develop symptoms of psychosis. So again, 6% is not the majority, but you know, when you're the one talking with the psychosis affected person, that's relevant. And so it's very, very dangerous category of drugs. Having said that, there are case reports of individuals with schizophrenia who are given therapeutic doses of amphetamine and do better with that. But the majority of schizophrenia affected people on amphetamine will do worse with that. So these are a category of medications. So as recreational drugs, they are massively destabilizing. And as therapeutic agents, the odds favor them being unhelpful. But if they're used, they should be used with great caution and careful monitoring. So that's the word. That's the word on amphetamine. Next slide, please. Marijuana. We're living in this very interesting time where individual states have taken it upon themselves to recognize something as medicinal. This is something that the FDA has had sole authority over for 60 years. And if you wanted to make a claim that anything was medicinal, you had to submit evidence to support the medicinal claim, and you had to support lots of data about safety. So that individual states can recognize marijuana as a medicine is very interesting and very novel and very clever. And for the record, I'm entirely pro-legalization. I think it should be that all the way, but that's a different story. I'm talking about safety, because just because something is legal doesn't mean it's necessarily safe. Tobacco is a great example. But states are saying we recognize marijuana as medicinal and in some cases recreational. But in the medicinal claims, the claim for efficacy is based upon really kind of scattered science, and in contrast to how FDA regulation goes, it's without review of safety data. We have, because marijuana was Schedule 1, was illegal, like highly illegal, no scientist has decided to take it upon his or herself to endure the regulatory pain to study marijuana systematically. So we have an evidence base of 0 studies that say what are, at a population level, the adverse effects of marijuana. But we have no shortage of data to say that for some individuals in the population, marijuana will provoke a schizophrenia-like condition. It's either schizophrenia or it's schizophrenia identical cannabis-associated psychosis. So some data, and each of these points has been, replicated many times. Marijuana users have earlier ages of onset of schizophrenia than marijuana non-users. We see also a dose or an exposure risk gradient, so that a little bit of exposure raises subsequent risk of schizophrenia a little bit, like 50% or twofold. High degrees of exposure, either with frequent use or use of high potency cannabis, exposure is correlated with risk rates of 3-fold to 9-fold of population averages. So the amount you take is proportional to the risks that you get for later in life. And we also, in first episode cases, have seen that in this particular case, this is a study from the UK involving 2,000 first episode individuals, and they found that cannabis use occurred in about half of their sample. And schizophrenia, first episode schizophrenia that was associated with cannabis use was also associated with more frequent rates of hospitalization, more frequent use of involuntary treatment, and higher degrees or higher rates of medication switching or medication polypharmacy. And medication switching and polypharmacy are what doctors do when patients are responding to the things that they ought to do. So those are proxy markers of treatment resistance. So there's really no evidence that marijuana is helpful, and a lot of it that says that it's harmful. We will put together a PDF of this and send it out to everybody. If you want a link to a PowerPoint slides and video from my other Echo Clinic SE consult, you can see the PowerPoint slides or 15 minutes of narration specifically on marijuana risk. And also the bottom link, the open access review article. It's 30 pages of review to help you understand, or to help people who might be convincing that the risk is non-negligible. So let's move on to the next slide. You probably have heard, and when we open up to the full discussion, I'll be curious how many of you have heard directly. I'm imagining that most have, about CBD oil or cannabidiol oil. The part of the marijuana propaganda or the pro-legalization marijuana, that highlights the medicinal benefits, will talk about cannabidiol. And there's actually really some good science. There's some babies in that bathwater. The cannabidiol is one of like 9 cannabinoid compounds in marijuana. Cannabidiol, it seems to be psychosis reducing, and that seems to be epilepsy reducing. Cannabidiol is different than THC, what's usually thought of as the active ingredient of marijuana, which produces the high and presumably produces the psychosis risk. So in the popular press and the websites and the pro-legalization literature, they will highlight the benefits of cannabidiol, and you'll get asked about that. And in fact, there are, by my last count, 2 small single investigator studies that suggested that cannabidiol can be antipsychotic. They can reduce symptoms of psychosis. The doses of the cannabidiol used in those studies was 800 milligrams a day. And yesterday I looked, I hope that my university doesn't track me on this, but I looked up several CBD oil suppliers, and I found that if you want to buy 1 ounce of CBD oil, that would set you back about $30 to $40, and that 1 ounce contained 25 milligrams of cannabidiol. So you would have to buy a lot of little bottles and consume a lot of oil to get 800 milligrams of pure cannabidiol. So it's difficult to envision that somebody who's accessing ordinary sources of CBD will be able to get the desired quantity without getting a whole bunch of other THC in the mix. Stay tuned, because there is I don't know how they managed to do this, but a company has managed to take a naturally occurring drug, cannabidiol, and get a patent on it, and they're branding it as Epidiolex. Epidiolex is set to receive FDA full approval for the treatment of epilepsy. And the last I heard, the FDA may be voting on that approval in June. So I'll try to follow that a bit. I think you might see some demand to it. But again, the science that supports schizophrenia reduction is quite small at the moment, but it may grow, and I myself am optimistic that it will prove to be helpful, because I think we'll be able to get people to take it, and if it actually is beneficial and safe in long-term use, that would be a major advancement to this field for sure. So next, helping to change substance use. We will talk, Russell Spieth, who works here at NeoMed, is going to have the lecture 2 weeks from now at the next ECWA session. He's going to talk about motivational interviewing. So these are basically some elements of motivational interviewing. So you'll have a whole lot to go from. But general rules, I think it's helpful that people know that the science is out there. You might want to just know that there are these people that say that using cannabis it might not be helpful. So just consider that. You probably don't want to say you need to stop this now, because you'll get tuned out. The basic principles of a probably helpful approach are ask a person, don't focus on the drug, focus on the person and what they want in life and what they want to achieve. So I say inquire about big goals. And the way most people answer this, you'll want to ask a follow-up question about the meaning of that goal. So for example, what's your goal? What would you really like to do? I want to buy my own house, or have my own apartment, and that's great. But it's always worthwhile to ask beyond that. Well, great. So getting your own apartment, that would be nice. What do you like about that? Or what you're getting at is, what does that mean to you? Because then you can tap into a whole bunch of stuff that might not necessarily require an apartment to be in hand next week. So I want to get my own place. That's great. What does that mean to you? Well, that represents freedom and independence and autonomy. And so if you know that those are the ultimate goals, then you can start to frame smaller goals that, so it sounds like autonomy is a really important thing to you. I get that. That's really great. Next thing on the list is point out their strengths. yeah, bullet number 2, look on or comment for their client strengths. So autonomy seems like a great goal. You know, in the time that I've known you, I see that you have this and this and this going in your favor. I really admire that about you, and I can see how these traits will really well serve your bigger goal of getting an apartment and being an autonomous person. So, you know, point out the strengths, because those strengths can be used eventually to overcome weaknesses. And so building on strengths is a great way to move people forward, not only in trying to get them to not use harmful substances, but in order to organize their life in ways that will better set conditions for healing. And then if you're going to specifically focus on drugs, then just in a nonchalant, non-judgmental way, great. So, you know, now that I've seen you have this and this and this about you that can really serve the goal of autonomy, I can see where that seems like a realistic goal for you. But I'm wondering, what do you think the marijuana has to do with this? Do you think that's going to help you, or do you think that has any drawbacks to it? So explore, and that's actually blended 2 things. You know, explore what, if they see any potential drawbacks to the drug use, as impediments to their big goals, but also understand that people use drugs because usually it serves some function for them. So, you know, I'm really curious. I know that you like marijuana. I myself am not a user of it, but I'm wondering, what does it do for you? You know, why do you like it so much? And understanding how it serves them opens up opportunities for trying to see if maybe there are ways that you can get bigger return with less use of substance. So if I use marijuana because it relieves my anxiety, then I have a way to talk about anxiety. And so I can say, well, yeah, no, I would want to not have anxiety as well. You know, some people have tried anxiety reduction by this and this and this. What about that? So we might be able to offer more effective ways to achieve their goals if we understand what the benefits that they perceive from the drugs are. And also, there can be probably no better way to change substance use behavior than by having somebody else who's been in that path to tell them how things are like. So I can talk all I want about how marijuana is probably harmful, but if somebody comes up to the using person and says, you know, I used to use marijuana too for a long time. I stopped and I noticed that I was able to not go to the hospital and I was able to get a job and so forth. You know, that lived experience from somebody who's a peer can be a lot more real than if it comes from somebody like you or me. And I believe that is the end of this slide. Yeah. So we'll move back to have all the squares. So yeah, questions, thoughts, comments, additions, criticisms? Yes, Skeech.
I appreciate. I mean, we get so many clients whose cases are complicated. One, just to be reminded that the samples that are studied are of a different breed, really, a different flavor of client. But I can see ways. There was somebody we talked about a team yesterday. I can see ways that we need to just kind of keep introducing them to some knowledge about what we've learned about marijuana use and how it can affect his chances, and then honor the fact that he's monitoring that. He was a little grandiose last time he was in psychiatry about his chances, thought for sure he'd never be hospitalized again. We just gently need to remind him that he's actually putting himself at risk some by that use, I guess.
Yeah, well, thanks for that. Thanks for that feedback. How many, you know, if those of you who have video, or if those of you who have video, raise your hand, and those of you who don't, please use the text function. How many? Oh, yeah. Okay. My question: how many have gotten inquiries about CBD oil?
Oh yeah,
Yeah, it's out there. So yeah, they will ask, and so again, the answer is it's been used, and it's 2 small studies suggest that it may be helpful. I think it's really hard to get the right dose based upon using CBD oil products that you buy from current suppliers. I mean, it's very expensive if you do that. And I would say stay tuned. Oh, but speaking of very expensive, if Epidiolex gets approved, its approval is going to be for epilepsy or for refractory epilepsy, and I'm going to guess that they're going to price it like $2,000 or $5,000 per month. I mean, because that's what drug companies do. So it'll be quite a while before it filters down to. I mean, it's my guess, but yeah, we'll take a pool. We'll take an internet. We'll organize like an internet poll, and we can all guess the price of Epidiolex when it gets approved. But yeah, go ahead.
Do we have a sense that the K2 does something different to the brains of folks than smoking marijuana? I mean, my son, I know, had K2 when he was a second-year college student, and I think it was the beginning of a lot of disorientation and disorganization and confusion.
Yeah, so I actually don't know that much about the